Hello, everyone, and welcome back to episode 15 of our Cincinnati Cancer Advisors Medical Minute podcast. So, Jill, last week we reviewed the results of my Garden 360, I'll put it in air quotes, liquid biopsy that I submitted a sample on December 22nd. You were so helpful on that. Thank you. So to get everyone up to speed with what we talked about last week, what those results were, I'm going to enumerate this. And Jill, I want you to do something different than you normally do, which is feel free to correct me if I say anything wrong. So the Garden 360 identified a specific biomarker called TP53V216L, or as I like to call it, good old TP53V216L.
Easy for you to say.
Yeah,
absolutely.
It's very easy for me to say. Mm-hmm. And so you've got a variant there being the V216. I still can't say it. V216L. Mm-hmm. But that's one that's often seen in lung cancer, colon cancer, and also prostate cancer.
Right.
And
multiple others, but those are the top ones.
The most
that you'll
prominent
see it in.
one.
Mm-hmm.
Yeah. Okay. Gotcha. And then so of those three, we can pretty much rule out colon cancer because I just had a clean colonoscopy a year or two ago. Mm-hmm. And then so we know that someone with lung cancer could have this biomarker, but not necessarily. And then we also know that prostate cancer can invade the lung and kind of look like lung cancer on a scan, but may not be. It still could be metastatic prostate cancer.
Correct.
So
and it does help that that it shows in prostate cancer, and we do know that you have
correct
active prostate cancer.
Correct. So now comes the detective work, and through PSMA scan, what the heck's wrong with me? PSMA PET scan, mm-hmm. and then we'll see where it leads from there. So we'll talk about that today.
Right.
So
did you enjoy your road trip up north?
I did. Thankfully, it's only like 4 hours to the middle of a cornfield
mm-hmm.
with nowhere to stop. Although there are some adult novelty stores that truckers go to apparently that are like on every other exit, but that's not really of much benefit to me these days. So anyway, so we got the PSMA done. We got the PSMA results mm-hmm. back, and so we'll discuss those today. So if you can just kind of quickly remind people kind of what a PSMA PET scan is, why it's so valuable in terms of highlighting maybe where prostate cancer might be hiding.
Okay. So a PSMA PET scan is a PET scan that is specific for prostate cancer. If you are a cancer patient, a PET scan was most likely part of your initial staging at diagnosis, and then quite often they'll do one at the end of treatment, as another data point. With a standard PET scan, you get injected with a radioactive type of contrast mm-hmm. that it's like a radioactive sugar, and the patients get injected with it. They have to wait an hour, and then they get scanned. And then what the scan looks for is areas that are breaking down sugar at a faster rate. That's what a standard CT PET scan does. What makes a PSMA scan different is that it is a prostate-specific membrane antigen. So that radioactive type of contrast that the patients get, it is specific to that prostate membrane. So it essentially attaches to that membrane, and then when they do the scan, they're looking for those areas that are lighting up on the PET scan, which are going to identify those areas of prostate cancer.
Got it. Okay.
The other piece to that, it's recently been FDA approved that contrast is mixed individually for the patient the day of the scan. Yeah. And it's not offered readily. You had to go to Michigan in order to be able to get it done. That was the closest site for us here. So for our prostate cancer patients, that is something else to consider, is that if a PSMA scan is something that's recommended as part of your treatment plan, that is something that, depending on your location, you may have to travel for.
Okay. Did I tell you I got to drink a vanilla milkshake with mine?
I do believe that you sent us a photo of the fabulous smoothie that
vanilla,
you also
great
got
vanilla, berry, chocolate, and then I don't know if mocha is just because I'm special, because I am fancy, mm-hmm. but I don't know if that was just for me or whether that's I don't know if that's normal or not. But anyway, okay, so So then why don't we go ahead and walk through what they found?
Okay. All right. So I want to preface the review of these results with the fact that we have already read these results and gone over them with Steve. I like to say that because as a clinician, when I review scan results, the last thing that I ever want to be looking at is a camera or a computer screen. Most often when I'm sitting down with scan results, I'm looking directly at the patient. So I don't want anybody to be like commenting how ice cold princess I would be. It's that I'm sharing these results with our listeners and our viewers for the first time. And I want to make sure that everybody has a clear understanding of what you are aware of already.
Yep.
So we're not going to read line for line the entire body of the PSMA scan. We're going to kind of jump to the Cliff Notes version and go into the specific interpretation. So when we look at the interpretation of the scan report, number one tells us that there is focally increased PSMA expression consistent with prostate cancer described in the full body of the report. So that's telling us that it did pick up increased activity specific to the prostate cancer. Yep. Number two, overall progression of disease in the pelvis with new enlarged hypermetabolic left common iliac and left internal iliac lymph nodes. Additionally, there is progression of metastatic disease with new enlarged hypermetabolic lymph nodes in the left supraclavicular region. Now, as we've talked about, we would expect to see enlarged lymph nodes in the prostate if we've got disease progression with the prostate cancer. The thing about this part of the report that was a little eye-opening and definitely warrants additional, just for us to dig a little bit deeper into, is the fact that we have a lymph node that's now lighting up in the left supraclavicular region.
Yeah.
Okay, and for those of you that don't know medical terminology, supraclavicular is above the collarbone. It's that area kind of at the base of the neck, right above that kind of squishy part right above your collarbone. So that's obviously a far distance from the pelvis. Right. And then number three, new left upper lobe lung nodule measuring 1 centimeter associated with hypermetabolic and additional more medial satellite mildly hypermetabolic pulmonary nodule. This is favored to reflect a new primary lung malignancy. Recommend FDG PET, which is just a standard PET, for further characterization and pulmonary referral. So what this is showing us is that there are two small pulmonary nodules that are showing up on this PSMA scan that were not there before. They are new, and they are hypermetabolic, which means that they're breaking down that contrast at a faster rate than normal cells would.
Got it.
So to kind of just briefly review, what this is showing us is that we've got disease progression in the lymph nodes in the pelvis. We also have a new lymph node just above the collarbone that was not there before. And we now have two new lung nodules that were also not there before.
Okay. So basically, this is the worst report card I've gotten since I got a D in geometry, pretty much, when I didn't think I was going to be able to let into the house by my father, but who gave me the disappointment speech, by the way.
I'm still staggering at the fact that you got a D in geometry.
Well, geometry is not math. Geometry, I don't know what it is, but it's not math. I can tell you that. It's certainly not algebra. We
are going to make a lot of people unhappy. We have slammed Michigan. You're saying that geometry is not math.
It's not,
we are so sorry. We're just going to apologize now for anything that we have said that would offend anyone.
All right. So anyway, so then, and I think you maybe even kind of touched on it a little bit, but I'm not sure the specific thing. So what do you make of this neck and lung thing? It is kind of a far way to go, right?
Absolutely. And the hard part of this is that quite often patients will just say, well, I've got prostate cancer. There's new spots. So obviously that's prostate cancer. And that's where you have to make sure without a shadow of a doubt that that is actually the case. And so, obviously the treatment team has talked, and your next steps are going to be doing a biopsy of that supraclavicular lymph node.
Okay.
The reason that we access that node for a biopsy is because there's a lot less risk associated with biopsying that lymph node. When you biopsy areas in the lung, there's a lot of complication risks that go along with it. And so if we have a new area that is easier to access with less risk to the patient, then that's the route that we tend to go. And we're not talking small risk. Patients who have lung biopsies, they can collapse the lung during the procedure. That can be severe enough that you would need a chest tube and end up in the intensive care unit. So it's not a small risk. So if you have a not necessarily easier route, but a less risky route, that's the way that most clinicians will go.
All right. So we often use movie references, right? So this kind of reminds me of Clark Griswold in Christmas Vacation, when he goes on his complete rant and then he ends it up with like, "Where's the Tylenol?" That's kind of how I feel right now.
Yes.
Now I do have one concern with this biopsy thing. I'm like, what about pumping iron? Am I going to have to take some time off from that? Because
no.
Okay.
No.
All right.
But
All right.
you
know, I'm all about that.
I know.
That.
You're looking for a reason not to have to run the vacuum. So the nice thing about a core needle biopsy is that it's an outpatient procedure. They may or may not offer some sedation, like a little bit of twilight. Sometimes, depending on the location, they will or they won't. It just depends on how in depth of a potential biopsy it has to be.
Okay.
And then if either way that they go, whether you get the sedation or not, then they numb the surface of the skin, and then usually they'll use some sort of like ultrasound guidance, and they will follow the needle into the lymph node that they're trying to access. And they have these great needles that it's a one-stop shop. You insert that straight into the lymph node, and it actually takes a chunk or a little core of that lymph node, and then it removes it, and you pull the needle straight out. And then that core piece of tissue goes off to pathology, and the pathologist will run additional stains and testing to essentially confirm what exactly it is that we're looking at.
Okay. All right. So I'm going to have that done tomorrow. So to recap, no food or anything, nothing to eat or drink in the morning, moderate alcohol consumption this evening, which is what I think you said.
I said no alcohol consumption this evening, none.
All right.
Thank you.
And then we'll see what those results look like, and we'll report back on that as well. So once again, everybody, thanks for joining in. This is a really important series that we're doing because it's as we mentioned before, it's early detection, and we know that leads to better outcomes, and that's what we want here at Cincinnati Cancer Advisors. So please like and share our podcast and subscribe, and we'll see you all back here next week.